Welcome back to the Long COVID and ME/CFS Holistic Healing Summit. We are so honored to be here today with Dr. Lawrence B. Afrin, and he's going to go through mast cell activation syndrome, through a whole bunch of stuff around that today. Some background for Dr. Afrin: he earned a BS in computer science at Clemson University in 1984, which is just down the road from me here in South Carolina, and then an MD at the Medical University of South Carolina, MUSC, in Charleston, South Carolina in 1988. While on faculty at MUSC, he was active in practice and research in hematology, oncology, and medical informatics. Since the mid-thousands, his clinical work has increasingly focused on mast cell disease, and he has an extensive record of peer-reviewed publications and has spoken widely in his areas of interest. And he's also the author of the book Never Bet Against Occam, so Occam's razor. Awesome. Dr. Afrin, thank you so much for being here with us.
My pleasure, Lorrie. Thank you for the opportunity.
Yeah, so Dr. Afrin has a whole presentation set up for us, and we're going to launch into that in just a few minutes, or just a few seconds here. But just to give you kind of an overview, Dr. Afrin, could you let us know what you're going to be covering, just a broad overview in your presentation?
This is going to be sort of an introduction to mast cell activation syndrome. It's turns out to be a disease with very complex underlying biology, which is why, in spite of it not really being a new disease, just a newly recognized disease, but my profession didn't even start to recognize the existence of this until about 15 years ago, and it's in large part the complexity of the disease, leading to different patients presenting very differently from one another. It just made it very difficult to see a commonality, so to speak, among all of these superficially very differently appearing patients, to understand that there really is such a disease.
Right.
And the complexity of the biology means there's a good bit of background to go through. I'm going to try to not get too sciencey, but there are some basics that need to be laid down. So this talk is really going to be about just explaining kind of the basic concepts of this complex disease. Not really going to talk much about specifics about diagnosis and treatment. I'll just kind of hit a few highlights of that toward the end. And we'll also, given what your summit is focused on, we'll also touch briefly on potential intersections between COVID and mast cell disease.
Right, and long COVID symptoms, and I'm assuming also ME/CFS kind of wrapped up all in there, right? Got a nice tangle of stuff in there. Yeah, and I know that just in taking a look at your presentation, also some possible practical suggestions.
Again, not a whole lot of time in the hour for this presentation to talk about treatments, and I think it's very important to note that the behavior of this disease is quite different from one patient to the next, and treatments almost always need to be highly individualized among these patients. So it's actually kind of difficult to come up with, broad recommendations applicable to everybody who is suffering the disease. So again, we just don't have a whole lot of time to get into specifics of diagnosis and treatment. This lecture is going to be just really starting, trying to help people to start understanding the essence of the disease, how it works, and the big picture of what it looks like at a clinical level. And you'll have to invite me back for another talk if you want to get into more specifics.
Okay, that sounds
diagnosis
good.
and treatment.
Yep, I'll take you up on that, definitely. Great. So we'll do some questions at the end as well. I've gotten just a couple of questions from some people in this audience and from some other places as well. So why don't we get into it? I'm excited to learn some sciencey stuff, as you said earlier today. Yeah.
All right, let me share my screen here. And all right, I think that should do it. Are you seeing my screen okay?
Yeah.
Okay, so let's get into it here. So again, thank you, Lorrie, for the opportunity to present today on current concepts, sort of introductory concepts to the notion of mast cell activation disease. And we're going to be reviewing basic concepts regarding the mast cell activation disorders, including kind of the new kid on the mast cell activation disease block, mast cell activation syndrome, or MCAS. We'll review the clinical presentation of MCAS and include a brief overview of the hypothesis of MCAS's potential involvement in COVID-19 illness, and as I mentioned a moment before, just very briefly touch on the broad approach to diagnosis and treatment of MCAS. I have no conflicts of interest to declare, and we just need to understand that any treatments described herein are ACCME level of evidence C. There simply are no FDA-approved treatments for MCAS yet. We'll talk briefly first about what we've long known about mast cell activation disease, and then spend the majority of the presentation on MCAS. So I want to start helping folks to understand the nature of this disease by illustrating a key point about the disease with the help of a couple of cases. Actually, the first two cases I saw in whom I came to recognize what was actually going on at the root of their illness was MCAS. But these two cases really well illustrate a key point in this disease, how at a superficial clinical level, it can appear so differently from one patient to the next. Because the first patient in whom I came to recognize MCAS, and I wasn't the first to discover this disease. Others had figured it out and published before I had, but this was my first case. A lady who came to me who had been diagnosed as having a relatively uncommon blood cancer called polycythemia vera, which is cancerous overproduction of red blood cells. And the next patient in whom I came to identify MCAS had exactly the opposite problem, where her bone marrow had given up making red blood cells. She had been given a diagnosis of pure red cell aplasia. And then just to further illustrate the marked variability and heterogeneity of the disease, want to briefly present yet a third case in a totally perpendicular direction. She came to me with a description, a diagnosis of burning mouth syndrome. So we'll get into these cases quickly here. The lady with P. vera Had been fairly healthy in her first 2, 3 decades, but then began to notice a migratory rash from time to time. And over time became more fatigued, developed some chronic fatigue, some itching, vertigo. She began having occasional falls, evaluations here and there. Pretty stoic woman, actually didn't go to the doctor very often, but when she did go, evaluations were repeatedly unrevealing. Finally, the fatigue got so bad, she went to the doctor again. She was in her early to mid 50s at this point in 2005. And the doctor, her primary care doctor, very reasonably checked a complete blood count, a CBC in her, expecting to find that somebody so fatigued would surely be anemic. And he was surprised to find that actually she had the opposite problem, a mild elevation in her hemoglobin and hematocrit and her red blood cell count. And he quickly sent her off to the local hematologist, who did what unfortunately at the time was really an insufficient workup for diagnosing this red blood cell cancer we call PVERA, PV. And based on the sort of preliminary test findings he got back, he incorrectly diagnosed this and began standard treatment for this disease, which actually is just draining the excess blood out of the patient, what we call therapeutic phlebotomy. And you'd like to think that if you give the right treatment for the right diagnosis, then the patient gets better. But she actually just kept getting worse in a myriad of different fashions, as you can see here, and ultimately got so fatigued and sick in so many different ways, she had to close her business. And her local hematologist kept insisting he had the right diagnosis based on the testing he had done, and actually just doubled down on the therapy, increased the intensity of it, and she just wasn't getting any better. Finally, because she couldn't get a referral out of him for another opinion, she referred herself for a second opinion and wound up in my clinic at the local academic center. And it took about 1 minute of talking to her to realize she couldn't possibly have PVERA because, well, I'm a hematologist. I know that disease. And yes, she had increased red blood cells, or at least had increased red blood cells before undergoing all those phlebotomies, but she otherwise really wasn't behaving anything like a PVERA patient should look like. And so I did the additional testing at that point to prove that she didn't have PV, but then the question became, well, what else do you have that was causing not only the initial increase in red blood cells, but also all the other problems you've been having? And actually, from the very first visit, there were a number of aspects to her presentation that made me wonder whether she might have this other rare hematologic cancer called mastocytosis, cancerous overproduction of the mast cells. But I did the testing that I had been trained to do to look for that rare cancer, and everything came up negative. And I spent many months and a lot of effort and money looking for other possible explanations for her symptoms. Really, everything came up negative. The more I saw her, the more it kept kind of smelling like it was like it was mastocytosis. And I kept reading more and more about aspects of mast cell biology and disease that I had never been taught in my in the 1 minute of training about mast cell disease that I had gotten in my 11 years of medical training. And through the reading, I eventually learned about other laboratory markers for mast cell disease I had never originally been taught about, including one called prostaglandin D2. I went testing for it. Initially, the test came back negative. It turns out to be a pretty tricky thing to measure accurately, but once I figured out the mistakes I was making and corrected them, indeed, we found an elevation in the prostaglandin D2 level, so that made me more confident I was headed in the right direction. with my thinking that she had mastocytosis. So now the question became, where was it? I mean, if it was a cancer of the mast cell, we ought to be able to find some accumulation of mast cells somewhere. So it clearly wasn't in the bone marrow where mastocytosis usually is, and it also wasn't in the skin that we had also done a biopsy of her rash. So next, I had done some reading that mastocytosis in some atypical cases sometimes shows up in the GI tract. So I sent her off for endoscopies, upper and lower, and asked for the special testing to be done on the biopsies, special testing that's absolutely necessary to be able to see whether there are any mast cells in those specimens. So on routine testing in the pathology laboratory, everything looked textbook normal according to the pathologist. But on the special so-called CD117 staining, this slide, by the way, the H&E staining is the routine staining, and this is a pretty normal looking segment of the intestinal tract. But with the CD117 staining, it became instantly clear that many of the cells that on routine staining had appeared to be other types of cells, such as lymphocytes that you commonly find in the GI tract tissues. Actually, with the 117 staining, it immediately became clear they were not lymphocytes, they were mast cells. And so I called her in and I said, I think we have a diagnosis of atypical mastocytosis. The question now is how to treat it, because there really wasn't much guidance in the literature at that point as to how to do that. We talked about a number of options, including one pretty pricey option, a drug that had recently become available, actually had been originally developed for a type of leukemia called chronic myeloid leukemia, CML, but some clever folks had figured out soon after it was introduced for CML that it could also help in many cases of atypical mastocytosis. It very clearly did not help in typical cases of mastocytosis, but her case was not a typical case. So I asked her to try it, starting at a very low dose and edging up gradually, and asked her to come back in a month. And she came back and told me that the first week she did fine, but didn't see any improvement. She then followed my instructions and doubled the dose, and then woke on the morning of the 5th day at the doubled dose, and just lying there in bed was instantly aware on waking that all of her symptoms were gone. Previously, for years, it had been taking her a couple hours every morning just to crawl out of bed because the fatigue had been so bad, and now she just leaped out of bed. And actually, that improvement has now been sustained more than a dozen years, and everything normalized. She was able to put her life and her business back together again.
Wow.
Literally the day after I saw that improvement, I did an initial consultation on another 50-ish woman who had been told by 5 other hematologists, academic and community hematologists, that the cause of her severe anemia was a pretty rare hematologic disorder called pure red cell aplasia, where the bone marrow just gives up making red blood cells. And this is usually due to either certain viral infections or other toxicities from exposures to various chemicals. But she really didn't have any of those explanations. Nobody knew why she had PRCA. She was heavily transfusion dependent. She was not responding to any of the typical drug treatments for PRCA. And she came to see me, and I actually never did figure out why she traveled as far as she did to come see me. But from all of the learning that I had done in the first case about mast cell disease, on taking this PRCA patient's history, I began to realize she too might have mast cell disease, this atypical mastocytosis, but just in a very different variant that was causing her bone marrow to put the brakes on red blood cell production. So I did testing in her for mast cell disease. You can imagine with all the evaluation she had had before that every other conceivable explanation for her problems had been ruled out. And indeed, we quickly found the evidence of the mast cell disease. And I was able to make at that point a diagnosis that was just coming into the literature at that point, not atypical mastocytosis, but rather mast cell activation syndrome, or MCAS. And with some cheap antihistamines alone, we were able to get a nice improvement in her hemoglobin in just a month. And she was no longer requiring transfusions, but she was still a good ways away from a normal level of hemoglobin. Tried a bunch of other drugs for mast cell disease. None of them helped. Eventually added on low dose imatinib, and in about a month and a half, that normalized her hemoglobin. We lost that improvement about a year later. And I was then able to move on to try another drug that actually was a lot cheaper than imatinib, still expensive, but a lot cheaper than imatinib, that her prior insurer had, for whatever reason, not allowed her to try. But she had moved on to a new insurer who did allow it. And with this other drug, cromolyn, we once again achieved remission in just a month. At the same time I was evaluating those two patients, I had already been scratching my head for 4 years at that point over another lady in her 50s I had been following, who had presented to me after about a year's worth of this constant severe burning pain throughout her GI tract from stem to stern, but it was by far the worst in the mouth every minute of the day. And honestly, the pain was so bad, I would even say 11 out of 10. How she did not commit suicide in all the years she had this pain, I don't understand. But extensive evaluations by every other specialist imaginable just came up with nothing to explain this new problem in her, until an enterprising endocrinologist wondered if she might have an unusual form of a fairly rare type of tumor or cancer called a neuroendocrine tumor. And so he did a screening test for that, a chromogranin A level, and indeed found her to have 100-fold elevated CGA levels. So he and others said, well, you must have a neuroendocrine tumor. And so she got sent to oncology and wound up in my clinic, because I was kind of the dumping ground at that point in my oncology division, dumping ground for the mystery cases. And so when I walked in the exam room the first time, it was obvious she was miserable from the pain. But you know, patients who have a cancer so advanced that a marker for the cancer is 100-fold elevated, you know, people with advanced cancer, they have a certain look to them, and she didn't look anything like that. And yet I had not been taught about any other possible causes for such a remarkably elevated CGA. So I spent a lot of effort, time, and money looking for the neuroendocrine tumor that my training had told me she must have, but I couldn't find it. I consulted many other neuroendocrine tumor experts. They all said she must have a neuroendocrine tumor. We don't know why the tests are negative, but just keep repeating the tests every 6 months or so, and the tumor's got to show up somewhere. And that didn't make a whole lot of sense to me. And I spent the next few years looking for a lot of other things, nothing turning up positive. And she just kept suffering the pain, nothing helped. And finally, around the time I was figuring out the mast cell disease in those first two patients, I began wondering whether this patient too might just have a very superficially different presentation of MCAS. I ran the blood and urine testing. That was all negative, but we did go back to our old GI tract biopsies, and bingo, there were the increased mast cells, but again, not in a pattern suggestive of mastocytosis. So we diagnosed MCAS and started her on some typical low-cost treatments for MCAS, and the pain got better virtually overnight. And I called up our chief oral surgeon. I said, "Do you see any of these burning mouth syndrome patients?" And he told me, "Oh yeah, hate seeing them. Nobody can ever figure out what's wrong with them. They're probably all just psychiatric cases." And I said, "Well, I got an idea. Why don't you send me a few?" And he was only too happy to do that. And every one of them I examined turned out to have MCAS in one variant or another, and they all started responding to various mast cell targeted therapies. And that was the subject of one of the early case series that I published about MCAS. So highly divergent presentations, but the same root disease. How can one disease do this? And could other weird presentations be possible? And I'm going to answer those questions, but let's pause for a moment to back up and look at what we've long known about diseases of the mast cell, starting with the allergic diseases. Allergy, asthma, and so on. These are very prevalent diseases, actually estimated to be present in about 10 to 20% of the worldwide, the global population these days. We know the incidence and prevalence of these diseases has been increasing significantly in the last few decades. There are various theories as to why that might be, but nothing proven yet. There's fortunately a relatively small number of allergic patients who succumb to anaphylaxis and die from anaphylaxis each year. But otherwise, these allergic diseases fortunately bring relatively little mortality, but that doesn't even begin to describe the significant quality of life effects that they come to suffer for a lifetime. So it's a pretty significant spectrum of disease. Now let's switch from the prevalent allergic diseases to the very rare mast cell disorder of mastocytosis. First seen in the form of a pretty unusual rash that you're seeing in the pictures here, called urticaria pigmentosa, first described in the 1860s, and it was actually a decade later that the mast cell was first discovered, and then it took another decade to realize that it was the mast cells at the root of that weird rash. Took another half century to understand that mast cells could cause any internal disease, disease beyond just the skin. That's about when we started understanding that the mast cells produce and release a lot of different mediators. The first mediator ever discovered actually was heparin, a very potent blood thinner that doctors often use as a drug to treat conditions of excessive blood clotting. We began discovering more mediators, more mast cell mediators over time. Actually, it wasn't until the 1980s that we saw the first publication of just the concept that, gosh, we've got this disease of mastocytosis, this cancer of the mast cell, both in the skin and internally as well. These rare cancers where you have not only the cancerous proliferation of the mast cells, but you have the inappropriate activation of the mast cells, the inappropriate production and release of the mast cells' many mediators. So shouldn't there also be a disease where we have the inappropriate activation without having the cancerous part of it? So that was the concept that was first published back in the 80s. Over time, we began developing more classification systems for mast cell disease. In the mid-90s, a couple of groups first identified there's this one particular mutation in an important gene and protein called KIT. It's the dominant regulatory element in the mast cell. And this one particular mutation is found in most cases of mastocytosis. And finally, in 2001, the World Health Organization's classification system for mastocytosis emerged. And coincidentally, that was the same year that imatinib emerged for that form of leukemia, CML. Again, it was just a couple years later that we began to realize that imatinib was highly useful for the unusual cases of mastocytosis that did not feature that particular mutation in KIT. And so in the last 20 years or so, we've increasingly come to understand that the cancerous proliferation of the mast cells that you see in mastocytosis really only causes clinical trouble in pretty rare and aggressive forms, very unusually aggressive forms of mastocytosis. Really, what's causing the clinical troubles in the vast majority of patients who have mastocytosis is the inappropriate activation of those malignant mast cells. So we'll now switch from that rare disease of mastocytosis. And well, before I get into MCAS, let me just illustrate here. So this is the spectrum of mast cell disease we've long known about. It's kind of this mountain of mast cell disease. This is not drawn to scale, but you see the general idea here that the bulk of the mountain, actually the vast bulk of the mountain, are the allergic disorders. And at the very top, the tiniest portion of the mountain is all the different forms of mastocytosis, both cutaneous mastocytosis, as well as all the different forms of systemic mastocytosis. Cutaneous mastocytosis is about tenfold more common than systemic mastocytosis. We see the cutaneous form a lot more often in children, and systemic mastocytosis a lot more often in middle-aged and older adults. So the whole mountain features inappropriate activation of the mast cells, but it's only that tiny tip of the mountain that additionally features the grossly inappropriate, the cancerous levels of proliferation of the mast cells. So now let's switch to a discussion of mast cell activation disease, or MCAD. Now again, the first notion that there ought to be a disease of inappropriate activation of the mast cells without having the cancerous overproliferation of the mast cells, that came out in the 80s. But you have to fast forward about a quarter century before you see the first case reports of what we now call mast cell activation syndrome. And some of these patients had that same mutation in KIT that you find in patients with mastocytosis, but some did not. And this was also the same year, 2007, that we had the first study of a series of these MCAS patients that showed that actually most of them did not have mutations in KIT. The great majority of them actually have well, they didn't have that one particular mutation in KIT that you almost always see in mastocytosis. And instead, most of these patients actually had a wide variety of other mutations in KIT. And in the years since, a number of other studies have shown that there are quite a number of other regulatory genes in the mast cells that are commonly mutated in patients who have not only mastocytosis, but also MCAS. In 2010, we had the first study showing that again, most MCAS patients do have mutations in KIT. And healthy patients almost never have mutations in KIT. So it increasingly is looking like it is these mutations in KIT and the other mast cell regulatory genes is actually driving the misbehavior of the dysfunctional mast cells in this disease. That year, 2010, was also the year we saw the first published proposal of a change in the terminology of this disease, changing from mast cell disease to mast cell activation disease, on the new understanding that first and foremost, what's going awry in all of these mast cell patients is the inappropriate activation of their mast cells. And it's just a tiny proportion of these patients that unfortunately are also suffering the cancerous overproliferation of the mast cells that defines mastocytosis. And this paper included the first specific proposal for diagnostic criteria for a mast cell activation syndrome, but there were a lot of problems with that proposal, and an alternative proposal. And full disclosure, I was one of the co-authors on this alternative proposal, came out just a few months later, suggesting a broader way of thinking about this disease. The original proposal was revised the following year, but still was problematic. That group says they more recently updated it, but in truth, it's really just a republication of the original revision in 2012. Just a quick mention that in 2016, the WHO revised its diagnostic criteria for mastocytosis, but they recognized at that point the controversy between these two camps of thought about the diagnostic criteria for MCAS. And so they pretty wisely stayed out of that fray and didn't make any statements regarding MCAS. We'll have to see whether they wade into that in the future. And in 2020, the alternative proposal underwent its most recent revision, and that paper then described more explicitly these two camps of thought, describing the first camp as having a proposal that some now term as consensus one, versus the alternative proposal that again, full disclosure, I mostly align myself with, the consensus 2 proposal. So this is the new understanding of the full landscape of mast cell disease. The mountain that we used to see is now recognized to be itself just the tip of a veritable iceberg of mast cell disease, where the part of the iceberg that's easily visible above this waterline, so to speak, of pretty easy clinical recognizability. These are the mast cell disorders that we previously knew about, whereas submerged below this waterline of easy clinical recognizability is this vast pool, this bulk of mast cell disorders, mast cell activation disorders we're calling the mast cell activation syndromes. And we really have not learned well at all yet how to distinguish the different forms of MCAS like we distinguish different forms of mastocytosis. It's going to take an awful lot more research in the decades to come to really start picking apart all these different variants. But the point is that the whole iceberg is now understood to feature inappropriate activation of the mast cells, but only the tip of the iceberg features inappropriate proliferation of the mast cells. There have been increasing estimates over the last 15 years or so about the likely prevalence of MCAS. Recent estimates suggesting anywhere from 17 to as much as 20% of the population, at least the Western first world population, may actually have MCAS, though obviously at this point, most such patients are not yet recognized as having MCAS. A few other quick things about normal mast cell biology. These mast cells, they are a type of white blood cells. So like all blood cells, they are born, so to speak, in the bone marrow from stem cells. Not too many of these mast cells in the bone marrow, and they don't spend much time in the bone marrow. They leave the bone marrow pretty quickly after being derived from the stem cells. They circulate in the bloodstream quite briefly as well before exiting into various tissues all throughout the body where they complete their maturation. They're pretty sparsely distributed in most tissues throughout the body. Where you dominantly find them is at the environmental interfaces, so the skin, the respiratory tract, the GI tract, and the genitourinary tract. So they're at the environmental interfaces and in the walls of all blood vessels and nerve pathways. And this is where you kind of expect to find them so that they can best serve their well-recognized principal role in human biology as the first line sentinel in our immune system, alerting the rest of our body to any assaults or insults upon the body. Other cells in the immune system, like the lymphocytes, take hours to activate after our bodies have been invaded or assaulted. The neutrophils take minutes to activate, but the mast cells can activate in sub-second time. They are the first line sentinels of defense against external elements. They typically live anywhere from several months to perhaps a few years. Their principal function is to synthesize a vast array of different substances we generically call mediators, and different sets of mediators get released by mast cells upon these cells sensing different types of assaults upon the body. And it's also important to understand that this regulatory element in the mast cell, this protein called KIT, that's derived from the gene called KIT. KIT is present on the surface of the mast cell tenfold more brightly than you find KIT on the surface of any other type of cell in the human body. And these, you have to have these normally expressed high levels of normally structured, normally functioning KIT. In other words, unmutated KIT at the surface of the mast cell for the mast cell to be able to pursue many of its critical functions, like just surviving and activating the mast cells in appropriate circumstances. This is about as sciencey as this presentation is going to get, just a very simplified, actually, illustration of the basic biology of what's happening here. At the top of the screen, you see that KIT usually sits at the surface of the mast cell in pairs of KIT molecules, what's called a homodimer. And another signaling molecule in the body called stem cell factor comes to engage with the pair of KIT molecules. And when you have that binding, that engagement, there's immediate change in the shape of the internal portion of the KIT molecule. And that change in the intracellular domain of KIT leads to instant activation of a wide variety of downstream molecular pathways in the cell that results in all these critical functions like keeping the mast cell alive and actually activating the mast cell. Most doctors learn in their training that there is a so-called classic method for activating the mast cells. Most doctors don't even learn about the stem cell factor method of activation of the mast cells, and instead they learn that most mast cells in the typical allergic setting, the way mast cells get activated to release their mediators and cause all the allergic symptoms is when some allergen actually comes to bind with a pair of antibody molecules called IgE molecules that have already been sort of pre-bound to IgE receptors on the surface of the mast cell. And when you have that binding of the allergen with the IgE molecules that are already connected into the mast cell, That leads to instant activation of the mast cell, release of the mediators that cause the allergic, even anaphylactic symptoms. But it turns out there are an awful lot of other ways to activate mast cells. Various physical stimuli, various other mediators and chemical signals that are produced and released by other organs and systems in the body. Even certain types of drugs can actually activate the mast cells. And another way to activate the mast cells have these receptors called toll-like receptors, and this is a key mechanism by which the mast cells instantly recognize the invading presence in the body of various microorganisms that are trying to establish infection, and that'll just instantly activate the mast cells to release various mediators to start marshaling other elements of the immune system to fight off the infection. So just to illustrate how quickly the mast cell activates, this is courtesy of Dr. Theo Theoharides, an internationally recognized mast cell researcher at Tufts University in Boston. And when I start the video here, you'll see what happens when a single mast cell in the center here comes to be contacted by a single molecule of a triggering mediator called substance P, which is a pain transmitting mediator. So watch how quickly here you see the outpocketing, the explosive outpocketing or degranulation of the mast cell when one molecule of substance P comes to engage a substance P receptor on the mast cell. This gives you a sense of just how quickly and voluminously the mast cell is releasing its mediators when triggered. So the mast cell is capable of synthesizing and releasing actually more than 1,000 mediators. And in case you're getting bored listening to me, I'll put up at the bottom of the screen this ticker so you can see all these other mediators that are put out. This list you see on the page right here in tiny print. You can't even, too small to even read. You know, it looks like there are a lot of mediators here, but actually this list is just a tiny subset of the entire vast list of mediators produced by the mast cell. So we think, again, this is a very prevalent disease. There's been increasing evidence in the literature that mast cells are intimately involved in a wide variety of chronic inflammatory diseases. And now that we're beginning to understand that there does exist this mast cell disorder called MCAS, mast cell activation syndrome, it becomes a legitimate question as to what proportion of the patient populations that bear each of these other chronic, mysterious inflammatory diseases might actually have one variant or another of MCAS at the root of these diseases like IBS and chronic fatigue and so on and so forth. So research for decades to come. So we think this disease is driven by various mutations in various regulatory genes in the mast cells in almost every patient who has the disease. Another word for the mast cells having mutations in them is that they are clonal mast cells. And we know from the research that most MCAS patients actually don't have just one mutation in KIT. They actually have multiple mutations in KIT. But unfortunately, in the clinical laboratories at present, the only mutation we can actually test for is the one mutation that shows up in almost every case of mastocytosis. We can't yet test in the clinical laboratories for all of these other mutations. We can only test in research laboratories for those other mutations. This is just a listing of many of the other mutations that have been found in KIT so far, just trying to illustrate here that the mutations in KIT in various MCAS patients are literally littered all throughout the KIT molecule. So there's just an almost uncountable number of ways that KIT can be dysregulated, and that leads to dysregulation or misbehavior of the mast cell. So to go back and answer the original question, how can one disease cause so many different problems? Well, this is how. Mast cells produce and release not just scores, but actually many hundreds, more than 1,000 different mediators. And any one mutation just in KIT alone is going to lead to abnormal release of many different mediators, creating some potential for multi-system illness and clinical variability from one patient to the next, depending on which mutation is driving the abnormal release of which mediators. But it's a lot more complicated than that, because we know most of these patients don't have just one mutation in KIT. They've got multiple different mutations, and different patients have different sets of mutations in KIT. But it's more complicated than that, because we know it's not just KIT that's mutated in most of these patients. It's actually multiple mast cell regulatory genes that are mutated in most of these patients. And it's even more complicated than that, because each mediator that's getting inappropriately released by these mast cells doesn't have just one effect in the body. Each mediator has its own unique, huge array of effects: direct effects, indirect effects, local effects, remotely located effects, acute and delayed and chronic effects. And so this is the manner in which one disease, so to speak, actually has biologic potential for causing such a dizzying array of different presentations in different patients. So with its potential to look so differently from one patient to the next, is it possible to come up with sort of an overarching, sort of a general description, a unifying description of what these patients tend to look like? And yes, it actually is possible to do that, because the majority of the mast cell mediators have effects that fit into one or another of three broad themes of activities in the body. First of all, inflammation. Chronic multi-system inflammation, that is the universal constant in all MCAS patients. Then there's a second category of allergic type phenomena, and I say plus minus on this because there are plenty of mast cell activation syndrome patients who do not have a speck of allergy to them, and then others at the opposite end of the spectrum who are literally in 24/7 anaphylaxis. And everybody else with MCAS is somewhere in between those polar opposite ends of the allergic spectrum. And then there's one other plus minus on this, and this is the hardest of all to clinically recognize, because these effects from mast cell disease emerge much more slowly. They emerge and develop much more slowly than the inflammatory and allergic effects come out. But it's it turns out that many of the mast cell mediators are intimately involved in guiding growth and development in all tissues throughout the body. So if those mediators are being inappropriately released by the mast cells, you can imagine you can get an awful lot of different types of abnormal growth and development in potentially any tissue in the body. Fortunately, the vast majority of these abnormal growths are benign, but occasionally they can even be malignant. So these patients typically have onset of symptoms by no later than adolescence, quite commonly even in childhood, occasionally even in infancy. But it typically goes unrecognized for decades because no doctors have yet been taught this disease exists. The overall natural lifetime course of the disease, it's always waxing and waning to some degree, but the baseline about which it waxes and wanes tends to be pretty stable for long periods of time to come. But then from time to time throughout a mast cell patient's body, the disease can significantly escalate in the baseline level of misbehavior of the dysfunctional mast cells. And these escalations tend to shortly follow by anywhere from a few days to at most a few months, shortly following a major stressor, either a major physical stressor or a major psychological or emotional stressor. So this is the overall natural lifetime course of the disease. So it's almost always a multi-system disease. Doesn't necessarily mean that every system will be affected, but it has potential to affect every system in the body. Again, inflammation is the multi-system inflammation is the universal constant. It's a perplexingly inconstant course. Again, this waxing and waning going on all the time. Externally, patients often look completely healthy, but inside they feel like crud in a huge variety of different manners. We've learned over time that tryptase, the tryptase level in the blood is a pretty good marker for the rare mast cell disease of mastocytosis, but not so great a marker for mast cell activation. If it does mark in mast cell activation, it's probably for anaphylaxis, but anaphylaxis is only seen in roughly 5 to 10% of MCAS patients. These patients, so instead of concentrating so much on tryptase, you really need to, if you're going to find the laboratory evidence of the disease, you got to look at a variety of other mediators that the mast cells are putting out. But of course, you want to constrain that to mediators that are relatively specific for the mast cell and are not being released by other types of cells. And the problem is that with many of these mast cell specific mediators, it's actually kind of technically tricky to accurately measure them. So there's a good bit of work the doctors and the laboratory staff have to put forth to accurately measure these levels. These patients, very understandably, wind up seeing lots of doctors. They acquire huge lists of problems and diagnoses. Many times, understandably, when no unifying diagnosis becomes apparent, they get thought to be psychosomatic and often dismissed by various doctors. And put yourself in their shoes. If you had seen so many doctors undergo so much evaluation, tried various treatments, and got nowhere, you would learn to shut up and just take it. This is the way I am. Nobody's ever going to be able to help me. So they stop reporting their symptoms. They've learned there's no point to it. And therefore, when these patients then are seen by a doctor and the doctor comes to suspect they might have a mast cell activation syndrome, it becomes very important for the doctor to actually extract from the patient all the symptoms they've been having, which in many cases they stopped telling anybody about long ago. The constitutional issues of this disease are all over the map. These are the patients who often have lots of weird reactivities that never really make any sense to the doctor, like allergies to Tylenol and Synthroid, drugs that it's virtually impossible to truly have reactivity to. And in truth, those patients are not reacting to those drugs. It's rather the fillers and the binders and the dyes and the preservatives, the so-called excipients in those products that they're actually reacting to. And look at the theme here, system after system, inflammation, 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 inflammation is what's going on here. System after system, it's inflammation manifesting in different ways in different systems in the body, the lymph nodes, the lungs, the heart and blood vessels, the GI tract often presents with just very puzzling, alternating diarrhea and constipation. The genitourinary tract is commonly involved with inflammatory issues that often get mistaken as infections. One urinary tract infection after another, and yet you do the urine testing, and with many of those tests, you actually can't find any infection. And that's because there is no infection. It's just inflammation. Inflammation is going to hurt, whether it's driven by infection or if it's non-infectious inflammation. The muscles, the bones, the joints are often involved in this disease. Again, inflammatory issues like pain, We talked about how mast cells are found at the environmental interfaces, so all aspects of the integument, skin and hair and nails and teeth, and gums are often involved. Absolutely, these cells interact tightly with both the central and peripheral nervous systems. So you get a wide array of neurologic symptoms, sometimes even psychiatric symptoms. And one of the most common complaints in mast cell patients are the cognitive dysfunction that comes from the disease. Hematologic issues, as you saw at the beginning of this presentation, are all over the map with high or low red blood cells, white blood cells, platelets, increased clotting, decreased clotting. One thing that puzzles many hematologists when they first come to learn about this disease is how the bone marrow itself often looks completely normal. And the immune system too can be impacted with all sorts of troubles, as you see here. The endocrinologic and metabolic issues are all over the map. You can have thinning of the bones, you can have thickening of the bones, too little thyroid activity, too much thyroid activity, sometimes severely abnormal levels of cholesterol and triglycerides, the growth and development anomalies in all sorts of different tissues throughout the body are all over the map. There's even emerging some suspicion that MCAS may underlie some proportion of the patients who have various forms of autism. So with a disease that's presenting in such a broad array of fashions, how do you come to suspect it? How do you diagnose it? Well, physicians have got to resort to their old best friend that many of them unfortunately just don't have a whole lot of time for, but that's taking a complete history and physical, and they have to renew their faith in this old tenet called Occam's razor. I mean, think about it. These patients who come to the doctor with a problem list of, 63 different problems, where the great majority of them are inflammatory in some respect. What's more likely? Is it really more likely that that patient is so uniquely unlucky as to have acquired multiple different problems, all of them developing independently of one another? Or is it more likely they've just got one thing going on that's actually biologically capable of causing most or all of the findings? And obviously that's the more likely explanation. It's just been a pretty biologically complex explanation that, thanks to that complexity, we haven't even realized exists up until just recently. Now, just because somebody has a mast cell activation disorder doesn't necessarily mean it's impossible for them to develop other problems. So the astute diagnostician does need to carefully consider whether other diseases which have symptoms that can overlap with what can be seen in some MCAS patients. You need to consider a lot of alternative diagnoses. There are even these rare genetic disorders called the autoinflammatory syndromes. Used to be very difficult to test for these, but now it's pretty easy and cheap to test for these diseases. And you have to make sure you're not missing the presence of these diseases in addition to the mast cell disease. To switch briefly to the how COVID might come to intersect with mast cell disease. This is a figure from a hypothesis article I published a couple of years ago with a couple of very MCAS savvy co-authors, Dr. Weinstock and Dr. Molderings, illustrating that, we were trying to understand why is there a difference between the roughly 80% of acute COVID infected patients who have a so-called mild to moderate course of the disease versus the 15 to 20% who have a very severe course of the disease. They need hospitalization, possibly a ventilator, high risk for death. What's the difference between those two broad populations? of patients. And similarly, with regard to long COVID, why is it that, you know, roughly 80% of folks who get COVID don't get long COVID, but another roughly 15 to 20% do get long COVID? And if you look at the patterns of the inflammation, the so-called hyperinflammatory cytokine storms that differentiate the severe acute COVID patients as well as the long haul COVID patients, you begin to pick up clues that it might well be mast cell activation that's maybe not the exclusive factor in that's distinguishing these populations, but maybe nevertheless a key factor. So this is a hypothesis article that we published at the time, and since then there have been many papers that have come out showing that indeed mast cells are activated in COVID disease, acute COVID and long COVID. But none of these papers really specifically address the issue of, you know, maybe the reason for this 80-20 difference in these populations is specifically a mast cell activation syndrome. You know, it's not just that mast cells are getting activated by the virus. In fact, mast cells are a first-line defense against viruses. You expect there to be some degree of mast cell activation anytime you have any viral infection. But why this 80-20 split? And maybe the reason is that it's the 20% of folks who have abnormal mast cells, and it's those abnormal mast cells that are reacting quite inappropriately to the virus, and that's what's leading to the severe acute COVID and the long haul COVID. So recently there was the first study to be published. I was one of the co-authors on this, that started to look at this notion of whether it specifically is MCAS that's at the root of what's going on in many of these long haul COVID patients. And I don't have time to go into the details, but you can see that there is an awful lot of similarity in the profiles of what MCAS looks like and what long haul COVID looks like. So an awful lot more research to be done. This absolutely does not prove that MCAS is what the distinguishing factor is, but it's food for thought, and probably worth pursuing further research to better vet this idea. So I don't have time to go into the diagnostic workup for the disease. Suffice to say that first you have to establish suspicion, and then you pursue initial testing, often as simple as just checking a tryptase level to make sure you don't have to go looking for doing biopsies to look for mastocytosis. But in most patients with MCAS, you do have to go to the third step in the box below here to test additional mast cell mediators. Most of these patients seem to live a pretty normal lifespan, so it becomes important to diagnose this and to treat it and get them feeling better for the remainder of a normal lifespan. Treatment, we don't really have time to go into. Just in general, we want to identify and avoid their triggers as best as possible. It is unique, a unique set of triggers in each patient. We want to try to inhibit the production of the mediators. We want to try to inhibit the release of the mediators. We want to try to block the actions of any mediators that manage to get released anyway. Keep in mind, this is not a cancer, so there is only very rarely, if ever, any role for any cancer chemotherapy, any cell killing treatments. In theory, an allogeneic bone marrow transplant, a stem cell transplant, ought to be able to cure this disease, but man, that's a tough procedure, and nobody has tested that yet in MCAS, and there's no way anybody should be doing that except in the context of a very carefully designed and monitored clinical trial, and that's not going to happen for a long time to come. And finally, any issues that arise from the released mediators whose effects you could not block, you got to deal with those issues too. So there are also other alternative and complementary treatments, a variety of so-called natural substances that can help control the disease. This slide again just illustrates a wide variety of other anti-inflammatory supplements that can sometimes help in various patients with mast cell disease. And there even are some non-pharmacologic therapies that are beginning to appear helpful in some mast cell patients as well. This probably relates to how closely the mast cells interact with the neurons in the body. Plenty of directions to go for researching this disease. We can keep armies of researchers occupied for centuries to come. In general, we want to try to improve the diagnostic techniques. It's hard to measure those mediators. It would be better if we could do the genetic testing to identify this disease. But it's probably going to be 10 to 20 years before those special genetic tests in the research laboratories actually migrate to the clinical laboratories. We also want to do research to better understand what's actually causing all these mutations in the first place, and then get much better at predicting which treatments are best going to help which patients. A lot of treatments to try, but no way yet to reliably predict which treatments are best going to help which patients. And that will bring us to the end. A little summary slide here. You've already heard me talk about all of this, and I'll leave it at that point for questions. Thank you.
Dr. Afrin, thank you so much. I know that I learned a lot. Perfect. Yeah, and I
stop the sharing here.
Yes, yeah, so we can see your face.
Do it?
Yes, you got it. You did so great. You're a wonderful teacher.
Thank you.
Yeah, and I want to let everyone know that we are gonna. Dr. Afrin has very generously offered a PDF of the slides. So I'm going to make that available to you because I know that we went through a lot of that pretty quickly. And then that way, if you want to do your own research on, in some of those areas, then you can do that. So we do have a couple of questions for you, Dr. Afrin. And this is one that came up to me because, and I know that you've run across this with working with your patients over the many years that you've been doing this, but I'm just thinking back to my clients and my students and all the people that I've run into within this ME/CFS, fibromyalgia, now long COVID, and even sometimes Lyme community. And just, I've seen just about every single thing within those multi-system symptoms that you went through over the years. And as you said, many times, a big chunk of those. One of the things that I didn't see in that symptomology, I'm just going to call it, that's probably not the right word, but was post-exertional malaise. And so I'm wondering if that does come along with MCAS sometimes, or if that is different.
It's also a common symptom. Again, I kind of bundled it into that two-word, chronic fatigue that I put up there.
Okay.
There's only so much room for so many slides and only so much room on each slide. But yes, many mast cell patients actually are triggered by activities of various. Sometimes they're triggered by engaging in a particular activity, even just briefly. Sometimes it's only after a certain extent of time or effort expended at that activity that they trigger the activation of their dysfunctional mast cells, and they start having one set of symptoms or another. And it might well be that different activities actually trigger different types of flares and different sets of symptoms.
Yeah. Huh.
So yeah, yes, that is something many patients with MCAS do report.
Okay. Okay. Interesting. And this question came in, and these are some things that I'm not super familiar with, just a couple of them. But the question is, do you have any experience with PEA, uh, palmito?
Palmitoyl ethanolamide, yep.
Yes, thank you. In
And,
order to calm down and to normalize overactive mast cells.
PEA is in a class of pharmacologic substances we call the endocannabinoids.
Oh,
And the cannabinoids, you know, we're talking about molecules that are related to the key molecules in marijuana. And it's been understood by the biologists for many years that the principal manner by which marijuana has its effects on the body, both the high that you get from a type of molecule in marijuana called THC, as well as various anti-inflammatory effects you get from a type of marijuana molecule called CBD or cannabidiol. These effects come about by engagement of these cannabinoid molecules with with cannabinoid receptors that are present on the neurons throughout the body. Well, it turns out there also are the same cannabinoid receptors, more or less, on the mast cells. And therefore, cannabinoid type drugs actually can be helpful in some MCAS patients. I'm not making a broad statement. I'm not telling everybody to go out and smoke marijuana. Actually, smoke is a bad idea for a
right,
mast cell patient.
right.
And so I'm not giving any individualized therapeutic advice for anybody on this. I'm just saying that there is a very clear route, a route in the established molecular biology here by which cannabinoids of various sorts actually do have potential for bringing about better control of the misbehavior of dysfunctional mast cells by these molecules engaging the cannabinoid receptors on the surface of the mast cell. In general, we really don't find, and there are always exceptions, you know, but in general, we don't find that THC, the high producing cannabinoid molecule, tends not to be all that helpful in MCAS. Rather, it's the anti-inflammatory cannabinoid CBD, cannabidiol, that tends to be helpful. And this is understandable because mast cell disease is a chronic inflammatory disease. So anti-inflammatories are a good thing to try.
Right.
For most MCAS patients. Again, there are exceptions. Everybody has to be treated individually.
Yes. Yes. Especially with this illness. Yeah. So the next question, what's the role of the HPA axis? You went over this, but what's the role of the HPA axis in the autonomic nervous system, uh, overactive sympathetic nervous system, and MCAS? So you can
Well,
go over that.
if we had another decade or so, I think we could cover that. But in just a couple of minutes, no, we can only barely touch on it. Look, the bottom line is that the mast cells are present in every tissue in the body, and all these different mediators that they are releasing do have potential for impacting the functioning of every other cell and tissue and organ and system in the body. And that includes all of the tissues and organs in the HPA system. And let's keep in mind too that you know, the neurons obviously are a, you know, key type of cell in the HPA system. And The mast cells are located quite proximately to the neurons throughout the body. And in fact, in many places in the body, the mast cells physically abut the neurons. I didn't have time to dwell on it. There was toward the end of the presentation a slide there, a microscopic picture that was illustrating with sort of red staining and green staining. It was illustrating how the mast cells and the neurons are directly abutting one another in some of the tissues in the body, and every place in the body where you have that dyad of mast cell and neuron together, there is constant mediator crosstalk going on back and forth between the mast cell and the neuron. And when the mast cell activates, kind of regardless of whether it's normal activation or abnormal activation, but when the mast cell activates, there is going to be further activation of the neuron, which is going to send increased signals all up and down the whole neural network that that neuron is connected to. And conversely, when the neuron gets activated, and this is regardless of whether it's from thoughts coming down from central or from sensations coming in from the periphery, but either way, when the neuron gets activated, the adjacent mast cell is going to get further activated. And conversely, when you simmer down the mast cell, you help to simmer down the neuron. And if you can figure out ways to help simmer down the neurons, you can help to simmer down the mast cells. But it's when you start to understand the anatomy here and the biology with, most doctors go through a decade of training, and in that decade, they get 1 minute of teaching about the biology of mast cells and about mast cell disease. And in that 1 minute, they get taught that the mast cell produces two mediators. They get taught that the mast cells produce histamine and tryptase, and that's it. So I think you could forgive any doctor whose extent of training about mast cells is that limited. You could forgive them for thinking there's really no way that mast cells can cause any more trouble than you would expect if there were extra histamine floating around in the body. In other words, kind of allergic type symptoms that we've long known histamine produces. But once you start learning that it's a whole lot more complicated than that, these mast cells are not putting out two mediators, they're putting out more than 1,000 mediators,
Right.
then you start realizing very quickly the potential that these cells, that this disease of abnormal behavior of the mast cells, the potential this has for creating just this enormous array of chaos all throughout the body. Again, I don't want to give people the wrong impression that the disease is necessarily causing crippling disability in every patient who has it. That's not the case. From what I've been seeing, that I suspect the vast majority of MCAS patients actually have the disease in so mild a form, they probably will never even need to know that they have MCAS. They occasionally have a little bit of an allergic problem whenever they go get some over-the-counter Benadryl or whatever, and that takes care of it. And so why do you need to know more about it if it's that easy to take care of? But at the same time, there are plenty of patients who are having more serious troubles with this, sometimes even disabling problems, even life-threatening problems. And how can you help those folks if you don't even know the disease exists?
Right.
So this is all an educational issue. I mean, come back in 50 years and every doctor coming out of training will know about this disease, just like today they come out of training knowing about diabetes and hypertension. But it's going to take a long time to get there. So go easy on your doctors. They've been doing the best they can, operating within the box um, that was the box of tools that was provided them in their long and expensive training. There's not a doctor on the planet today who is trained in this disease. Certainly not me, and not anybody else who has familiarity with it. Everybody who's familiar with this, they've largely been learning about it on their own, reading journal articles, learning from their patients,
Right. Right.
attending presentations, seeing videos like this one. This is how people are learning right now. It's going to take a long time to get to the point where the medical schools are formally, incorporating this into the curricula and teaching trainees in a clinic. How do you recognize that when a patient comes in for a visit? How do you get to a point in your head as a doctor where first of all, you have to be aware the disease exists. Then you have to get to a point in your head where you can look at the symptoms, the history in the patient, and look at the physical exam and actually develop the thought, the suspicion that, hey, maybe what's going on here is a mast cell activation syndrome. I mean, there are other possibilities too that might need to be considered, but maybe MCAS is one of those possibilities. And therefore, maybe some of the testing we need to do in this patient to figure out what's going on in them is mast cell focused testing. I want to be real clear here. The disease is absolutely capable of causing a million different problems. There's no question about that. But I am not saying that every chronically, mysteriously, multi-systemically unwell person out there necessarily has MCAS at the root of it. What I'm saying is that if you have somebody who has chronic multi-system inflammation, plus minus allergic type issues, plus minus abnormalities in growth and development in various tissues in the body, that those are the sorts of patients in whom it now becomes reasonable to include MCAS in the list of diagnoses, what we call the differential diagnosis, that is the reasonable set of diagnoses to be considered for that patient. And therefore, you then start evaluating and testing for it. And either you prove it or you don't. But that's all we're saying here. We're trying to help everybody, patients and doctors alike, come to understand, yeah, it exists. And not only it exists, but it's prevalent, which if you think about it, that means that in truth, every doctor has been seeing this left and right all day long, every day, their whole career. They just couldn't previously recognize it for what it is, for very understandable and forgivable reasons. They weren't taught about this. And every patient with MCAS shows up looking so differently from one another.
Right.
I mean, I myself, I was 13 years past the end of my training before I came to recognize this is what's going on in my first such patient. And then I started recognizing it in other patients, and 2, 3, 4 patients in, and then it hits you. Oh my goodness. All those patients I had seen in my prior quarter century in medicine, training and practice, all those patients I had seen who had inflammation and allergic issues and tissue growth problems, and I could not figure out what was going on with them, there's a good chance that they actually had MCAS at the root of it. And so actually, when that light bulb turned on over my head back in 2009, I started calling back. Some of those, I went through my
Wow.
charts. I started calling back some of those old patients and said, hey, I've got a new idea. I couldn't help you at the time, but I've got a new idea. Do you want to be reevaluated? And I'm not going to say that every one of those patients who I reevaluated turned out to have MCAS, but it turned out a lot of them did.
Wow.
And then finally, once you have the right diagnosis, you then apply the right treatments. And my goodness, I've learned it doesn't matter whether they've been sick with this for 10 years, 20, 50, 80 years with this. Once you make the right diagnosis and you apply the right treatments, they get better. I mean, what a concept.
Right.
You know?
Do you think that, so have you had any long COVID patients come to you?
Oh, plenty,
Uh-huh.
plenty.
And what have your findings been as
So
far as
far, I found MCAS in every single one of them.
everyone? I mean, it just,
And yeah, again, this doesn't prove that MCAS is present. It is the root issue in every long COVID
right,
patient. But, and keep in mind too, this is very important to keep in mind that my practice at this one, I mean, I was years ago in a general academic hematology oncology practice, but in the last several years, I've come to focus exclusively in mast cell disease.
mhm,
And you can also imagine that the patients who come to see me, not only are the ones whose courses through life have gotten them to the point where they or their doctors are coming to strongly suspect they have mast cell disease, but you can also imagine the patients coming to see me are the ones who probably have it a good bit more severely
right,
than other people. So I am
right,
unquestionably seeing a biased selection of patients.
right,
There may well be other subpopulations of long COVID patients whose symptoms just don't give anybody a reason to question, to suspect that they might have MCAS, and no, they're not going to come see me. But the patients who do come to see me with long COVID, so far, every one of them has turned
yeah,
out to have MCAS. And when we then prove it, and I mean, this is the implications of this diagnosis are too significant to just go guessing about this diagnosis. I mean, there are plenty of places in the world where they just literally don't have access to the testing for this disease. And sure, in those places in the world, you have no choice but to make a clinical diagnosis. You know, you make your best guess and you go with it.
right,
But here in the US, we're very fortunate to have access to the testing. Again, I'm not saying it's easy, but nevertheless, we do have access to the testing. And I think it's important that when you have access to it, then pursue it and get the proof that this really is what's going on. And then at that point, it becomes a much more legitimate affair to start trying the patients on all these different mast cell targeted drugs that we've learned about to see what's going to help. And what I've seen so far is that my long COVID patients who do get proven to have MCAS, yeah, we do find that one mast cell targeted cocktail or another really does start to bring them significant improvement. Let's be clear here. We're not curing this disease,
right,
okay? That we understand from, again, all this preliminary research that most people who have MCAS, it's rooted in various mutations in the mast cells. So we're not curing that anytime soon. I mean, that's going to take from pretty sci-fi, pretty sophisticated genetic engineering to really cure that. So that's not happening anytime soon. And you can't even control such complexity perfectly. So it's kind of irrational for anybody with this disease, with MCAS, to expect to get to a point of feeling perfect, if they even knew what that felt like, given that
right,
so many of them have been so unwell in so many different ways for so long. COVID may have made them even worse, but most of these folks were already having issues with the disease. They may not have even recognized that they had MCAS previously, but
yeah,
nevertheless, they were having issues with it long before. So you can't get those people to the point of feeling perfect. You can't even control such complexity well or satisfactorily for 100% of the time. So the goal that I've learned in managing this disease over the remaining decades of a patient's lifetime, the goal is to get to the patient to the point where they're feeling significantly better than the pre-treatment baseline the majority of the time.
Yeah.
And in my experience, we are fortunate that we got a lot of drugs that have been shown helpful in various patients. And thanks in large part to that, we actually are able to find one cocktail or another that actually does get most patients with this disease to the goal. Again, I'm not saying we're curing it. I'm not saying we're getting everybody to the goal. There are those unfortunate few who have some extraordinarily severe cases of this, and the aberrations in the biology in their mast cells is that they're just so screwed up in their mast cells that we just don't have any way yet to control it. There are those few unfortunate people, but on the plus side, they are few and far between.
Right.
Most
And
people who have this disease seem to get better. It's a process. You know,
yeah,
we have no way yet, no method yet for reliably predicting which treatment is best going to help any particular symptom in any particular mast cell patient. I'll be the first to acknowledge there is an awful lot of trial and error in working through the trials of the many different treatments available for this disease. But if both the patient and the treating doctor, both of them are patient and persistent and methodical, you know, trying to make one change in the regimen at a time
yeah,
as much as possible. You don't have to spend a long time with each drug that you're testing to see whether it's going to help or not. Once you find the drugs that happen to be the right drugs for the individual patient, for controlling the particular variant of MCAS that is present in the individual patient, once you find the right drugs for that patient's variant of MCAS, they come back in just a month or so, and the doc walks in the exam room and his head spins 360. It's so obvious how much better they are.
right.
It's just unfortunate we don't have any way yet to reliably predict which of those drugs is going to best help the individual patient. So yeah, I've had patients, even patients with long COVID, who have followed up with me, and you know, they're just, you know, one or two or three drugs into you know, trials of drugs for this, and they write me back, say, oh my God, you know, it's the first or the second drug I tried, and within hours or days I couldn't believe how much better I was feeling.
Wow. That's
But
amazing. Yeah.
there also are those patients who, you know, they're on their fifth drug, their 10th drug, their 15th drug. And you can imagine the mental fortitude and strength it takes to persist that long. But this is the value of having the laboratory proof too, because when you have the laboratory proof that says this is what's going on, then you persist and you have all these drugs that can work to control the mast cells in so many different ways. You just got to be persistent in trying until you find the particular treatments that will happen to control the particular type of misbehavior that's present in the individual patient.
Right.
So I have gotten completely off track with what your question was, but
Well, no, that was important. You answered my question, and then you went into another important point. We are going to wrap things up. I have two other questions that I'm going to send to you,
okay,
and maybe you can just type out the answers.
sure.
Yeah, yeah. But this has been incredible, Dr. Afrin. There were a couple of points throughout where I just got goosebumps because you know,
It's resonating.
yes, exactly. And resonating, and what I see with, you know, again, with the people with long COVID and ME/CFS and fibro and all those things that I interact with. So thank you so much for your good work and for your time, for your generosity, and for your brilliance. Thank
No.
you.
Others might question that, but in any event, thank you very much. You're very kind, and again, I appreciate the opportunity. Always happy to have opportunities to educate.